So we are live now.
Yes. Welcome everyone. We'll wait for maybe 1 minute only, and we will start to give a chance for more to join. Currently, we already reaching more than 1,000 attendees, and participants now is 1,300 currently. So I think we can start, and welcome everyone, and Bismillah ar-Rahman ar-Rahim. We will start our webinar for today, arranged by the Saudi Society for Blood Disorder. This is part of the MENA Forum for Challenges in Hematology, which starts on 7th of September 2020. It's in the last Monday of each month. We already done 5, and this is actually the 5th. We did 4 before, and we hope that today webinar will be as informative and helpful for everyone. First, I want to thank our sponsors who give unrestricted support to our activity, Janssen and Hikma. Today webinar is about graft versus host disease challenges. Of course, graft versus host disease is a hot, big topic, and what we will do today is only focus about the challenges and the update. And to do that, we are very glad to have our speakers. I will start myself. People who know me, I am Marwan Shaheen. I am a consultant in adult section of hematology and the stem cell transplant cellular therapy in King Faisal Specialist Hospital and Research Center, Riyadh. And also I am the director of the long-term follow-up program in King Faisal Oncology Center. Our speakers today is, we are honored to have 2 distinguished speakers. First is our previous colleague in King Faisal and a well-known physician and hematologist in long-term survivorship, GVHD. He's a world expert, Shahrukh Hashmi. He's currently in Abu Dhabi, chair of hematology and oncology in Sheikh Shakhbout Medical Center. And he still have the position of my clinic in Minnesota. He is also chief of many committee related to our today topics. Also, we are very glad and honored to have Dr. David Meklas, who is the chief of BMT and cell therapy in Stanford University in California. He is also a director of Stanford Cancer Cell Therapy, a well-known figure in hematology and BMT, also a worldwide expert of GVHD, who will talk today about advances in GVHD management. Dr. Shahrukh will give us, after that, staging and diagnostic challenges, which I think are very important to focus on. So if you allow me, I will start my presentation. Before I start, I want to highlight and mention that all our webinars are fully recording, and the records of the material is available in our channels in YouTube and Twitter, and you can access it anytime, free. So first, I will start by what is GVHD. Graft versus host disease is a systematic disorder and occur when the immune cells recognize the host as foreign and attacks the recipient by immune attack, and by having the graft as a transplanted and the donate tissue as a host. So the graft will attack the host, and this can happen in many of the tissues, of the recipient. It's common complication for allogeneic, but also it can happen with solid organ transplant. And in our hospital, for example, annually we saw one liver GVHD after liver transplant. Globally, approximately 25,000 allogeneic hematopoietic stem cell transplant performed worldwide on the year of 2012. I am sure now the number is more these days, as all countries have started more transplant. Chronic graft versus host disease occur in there is some reports that report a third of patients who will develop a chronic graft versus host disease. Other reports reach up to 70 to 80 percent. And we all know that graft versus host disease is a leading cause of non-relapse mortality and morbidity. And the standard first-line therapy is a steroid, and there was no approved, FDA-approved second line till recently, where only one medication approved in acute GVHD and one in chronic GVHD so far. Dr. David will give all the detail about the advanced therapy, but approximately half of the patients who started on steroid, they will become either dependent or refractory to steroid. And the classification of GVHD, the old days, it was with a cutoff of 100 days. So any graft versus host disease happened before the 100 days of transplant, we call it acute. And nowadays, all this change because with the new transplant, immune depleted transplant, using using target therapy, the acute graft versus host disease can happen even late. And this is not the 100 days, not anymore, but it's typically before the 100 days. In acute GVHD, there will be certain organs that are commonly affected, and in chronic, the behavior is totally different, where there will be many changes in pathophysiology with T regulatory and T cell and other markers that inflammatory and cytokines that will induce multiple organ damage. And there is also what we call overlap syndrome, when there is mixed feature, one organ with acute and the other organs develop chronic. So this is how we classify by the organ and by the manifestation. If you review the latest report from the CIPMTR data, which was up to December 2019, a year ago, and Saudi Arabia is one of the countries that participate in CIPMTR, you can notice that there is a continuous increase in the allogenic stem cell transplant, and there is also increased in the autologous, and also the haploidentical, which really started around 6-7 years ago to be a significant increase. And with the haploidentical, the risk of graft versus host disease is more. Not only this, the age of the transplant recipient is increasing worldwide, and many centers in North America and Europe are transplanting up to the age of 79 and 80 years. And this also led to more transplant, and of course, when transplant happened, more complication. Here, if you review the cause of death after HLA type full sibling transplant, or HLA matched sibling done in year 2014-2015, you can see that GVHD is 8% within the first 100 days and 7% after beyond the 100 day. And if you compare this to 2016 and 17, you can see that the graft versus host disease almost doubled in the acute and in the chronic. And this is not because the less management, because the behavior and the change of the transplant number and age of the recipient, also the therapy related, the target therapy prior to the transplant. This is for the non-matched or unrelated sibling. Again, the same can be appreciated. It's initially it was 10%, 10%, and recently it's increased to 16 and 14% for even unrelated donor. So there is an annual growth rate increase, and like I mentioned, with the increase in the survival also of patients with very good therapy before transplant. So more patients reaching transplant, and there is more to develop GVHD, and due to increase of the also worldwide number of transplant, there is more burden, and Saudi Arabia have the same. So this is a publication that we did published then Jeddah, King Faisal Jeddah, and in 2010, Dammam, King Fahad Specialist Hospital, and later National Guard Hospital, Riyadh and Jeddah. So currently we have almost 10 transplant centers in Saudi Arabia, and the estimated number of transplant of allogenic stem cell transplant annually is around 400 to 450 at least. Transplant. So if we say that up to 70% of them can develop GVHD, this is a huge number to have each year. And if we focus about the cost burden, there is many study which also evaluate this matter. And over a 1 year period of many studies, they noticed that acute GVHD experience over than 100,000 more in total healthcare costs, and nearly 3 additional weeks in hospital for patients who develop acute GVHD compared to other who was transplanted without GVHD. This is one of the studies that tested 6 important markets: US, France, Germany, Italy, and Spain, and UK. They tested in 2013, and they put the estimation in 2023. And you can here notice that you notice that there will be about annual cases of acute GVHD 8,000 in 2013. 10 years later, this will go up to 11,000, and this is the same situation with the chronic GVHD. There is significant expected significant increase. In one of the study, they noticed there is 16% of persons who died from acute GVHD compared to 5 without GVHD, 5%. This is significant. Also, there is a length of stay longer with acute GVHD, 54 days versus 29 days, almost double the duration of stay, and of course the cost and the charge you can count it. Everyone please can mute their mic, please. This is about the chronic graft versus host disease. Again, the burden is high, and then there is a loss of jobs, there is a long-term morbidity, mortality, and there is a cut of salaries, and they found it to the chronic up to 22% were reported in the literature as a premature mortality. If we take one example, in a patient who estimated the mean age of developing chronic versus host disease was maybe 51 years, for example, a person earning 50,000 per year with an estimate span of like 14 years of potential employment, this person alone is being prevented from working would yield in a human capital foregone of $700,000. Such a figure exceeds the reported hospital cost, and there is no caregiver cost charged in this calculation. This is one person. So in US, in 2015, there was 44,000 chronic GVHD. So this will cost 27 billion in a decade. And this is just an example for the cost. So what is the GVHD challenges? There's many challenges. First, the early diagnosis. There is a problem in detecting an early stage where the therapy will be more successful. And also when there is early diagnosis, there is a poor documentation, which will allow us, which needed to have a proper staging, then a proper therapy. And also one of the challenges is the lack of multidisciplinary team. In King Faisal, we started the long-term survivorship and GVHD long-term clinic with the help of Dr. Shahrukh Hashmi. There was a communication between ophthalmology, dermatology, and there is identified ophthalmologist, dermatologist, physiotherapist, pulmonary, gynecologist, and maxillofacial, for example. And then we also have lung transplant support when we need. And despite we identify those, there's still a challenge to cope with all patients during the visits. And it's a challenge to refer those patients to appropriate service with appropriate time. So what we need in order to help, we not need what we need is really first reliable molecular marker for early detection. This will give us a chance to identify our patient before they develop severe, life-threatening acute graft versus host disease. Also, before transplant, we need DNA-based tissue typing to make sure to have precise HLA matching between donors and transplant. We need to be careful with the T-cell depleted transplant and to utilize it and utilize post-transplant cyclophosphamide, and to have more uniform treatment of the disease in order to predict complication, and more targeted therapy, which is coming every year. I want to stop here and thank you. And the question and answer will be at the end of the presentation. Now we will go to next speech with our distinguished speaker, Dr. David Michaelis. I already introduced him. He's a chief of BMT in Stanford University in USA. And he will talk today about advance in GVHD management in 2020. Please go ahead, Dr. David. Please unmute yourself, Dr. David.
There you go. I'm 5,000 miles away and still muted. Again, I thank Dr. Shaheen and the meeting organizers, my good friend Shahrukh Hashmi, and the sponsors, Janssen, as well as the, of course, Saudi Society for Blood Disorders for this kind invitation. I am going to take about half an hour and try to hit the highlights, and I have incorporated many of the advanced trial results from the ASH meeting from last week. So I think this will be quite informative, and I'll try to skip through the staging aspects that it looks like Shahruk's going to touch on in a second. So if you can stop sharing, I will take the screen at this point. Thank you. Okay, if you could just acknowledge that you see my title slide, and that would be great. And now you're muted. Sorry, Dr. Sheen. Yes, thumbs up? Okay, thank you. All right, so this is terrific. I'm really excited to be here with you today. And what we'll try to do is move through the advances that were really presented at ASH of this year. And again, my disclosures are broad. I have moved from graft versus host disease into more efforts in chronic graft versus host disease, and then more recently CAR T cells. And I really have no equity in any of these companies. The beauty of an allo transplant is the transfer of the stem cell and established immune responses of B and T cells. This is able to provide both the benefits of graft versus tumor, which eradicates the cancer to the last cell, and unfortunately causes detrimental problems of off-site toxicity called graft versus host disease. As we have come to learn more about the immune system, we focus both on the MHC, HLA molecules, but also on their cognate, smaller minor compatibility antigens in this recognition. And what began with Dr. Jamie Ferrara's very simple three-phase cytokine acute GVHD model has evolved into things more complex. But in this study, we all thought that the movement of damage from conditioning and inflammation and possibly infection led to increased inflammation, which then results in activation of the T cells, macrophages, and potentially other cells, resulting in graft versus host disease of the skin with rash, gut, diarrhea, liver, bilirubinemia. But I think the more interesting work these days are coming through the thought that a human being is not just a single organism anymore, but carries about 10 kilograms of other organisms in our guts and in our bodies. And obviously this microbiome is having an important impact. My colleague here at Stanford, Dr. Ami Bhatt, gave a wonderful series of plenaries and scientific instructions at ASH last week. So if you have an opportunity to still view those, I recommend you look back with Marcel Vandenbrink and Ami. But in a sense, we're looking to see what the microbiota does as you go through a transplant with the addition of antibiotics and conditioning. This, of course, is changing. And we understand, of course, the damage to the intestinal epithelial barrier is also causing these leaky junctions. And so beneficial bacteria are being reduced, the harmful bacteria are overgrowing. We have activation of the signal 3 in the immune responses with DAMPs and antigen-presenting cells, and this is leading to an increased cytokine storm, as documented by Dr. Ferrara. But it's, of course, much more simple than a three-phase pathway, and I think this will be the model that guides our thoughts about the complexities of GI GVHD going forward. And I'm sure that in your patient population like ours, cytomegalovirus and other GI viruses are also a big problem and continue to be requiring our attention. Nonetheless, the standard GVHD immune prophylaxis in 2020 remains tacrolimus or cyclosporin with methotrexate. This has been since 1980s. It's associated with about 35% match-related donor GVHD and 50% with unrelated donors. There's a strong effort to test whether post-transplant cyclophosphamide will replace acute GVHD, and I'll speak to that trial in a second. As you know, chronic GVHD is the similar management of activated B and T cells following their adoptive transfer, and results in both less acute and chronic GVHD. It does deplete the graft versus tumor responses in ways that relapse becomes our major concern. It's been shown to be effective across matched sibling as well as unrelated donors, haplos, and mismatched unrelated donors. And so most people are using post-transplant cyclophosphamide in combination with mycophenolic acid and either calcineurin inhibitor or sirolimus. And there's a lot of work here as to how to manage the patients, especially the haplos, with higher T cell doses coming through with peripheral blood stem cell. It's our effort to still try and use bone marrow when possible, but COVID has made that very difficult. Our own institution is moving towards graft engineering to provide a known number of conventional T cells, regulatory T cells, and memory T cells. Now, I'm sure this is one of the slides that Shahrukh will speak to, and Dr. McMillan's important Minnesota staging criteria that show the change in risk with low or high, and I'll let him speak more to that, but it's relevant because if we're going to consider the therapies that are being presented as new standards for treatment of steroid refractory, we need to understand the high risk of the mortality shown here. And so if it was stage 3 or less skin or grade 2 or less GI, then that is relatively standard risk. And the overall response rates are 70%, but drops to about 40% with high-risk disease. More importantly, the non-relapse mortality by 6 months post-transplant is approaching 50% with high-risk disease. And in steroid-refractory acute GVHD probably exceeds 50%. So these are the problems that we face when the infrequent, but unfortunately, as was pointed out, increasing number of GVHD patients are being treated. The cooperative group in the United States, the BMT-CTN, has a trial called 1301 or Progress 2, which we hope will be resulted. Maybe Shahrukh will be able to update us on that. I think it might be updated for TCT as a late breaking. And this is a 3-arm study of over 300 patients as shown. Patients predominantly with leukemia, MDS, going through myeloablative conditioning that have an 8 out of 8 unrelated or matched sibling donor. Now you see that the 3 arms require different graft sources. So if you're using a 34 selected product, then you had to use peripheral blood stem cells. And if you were using the other 2 arms with either post-transplant cyclophosphamide or tacrolimus methotrexate, you had to utilize bone marrow grafts. I don't really think bone marrow graft for sibling donor with either PTC or TAC methotrexate is the standard in the United States. So it'll be difficult to interpret what this means when we finally receive the end results here. Nonetheless, randomizations are gold standard, and the endpoint is a chronic GVHD relapse-free or CRFS endpoint. We have to thank the PI leaders, Dr. Luznik, Perales, and Pasquini, who are bringing this important study forward. Now, when we complete the treatment of GVHD, which, as we said, was 2 mg per kg of prednisone plus or minus therapeutic tacrolimus and or sirolimus, then the definition of what is steroid refractory is very important. And we need to stick with this in our institutions if we're going to be able to speak the language to each other and also make sense of the data for steroid refractory. So progression within 3 to 5 days with more than 2 mg per kg per day of prednisone, or a failure to improve within 7 days, or an incomplete response after 28 days. These are the definitions of steroid refractory or steroid resistance. And steroid dependence is a different discussion that I don't really think is well defined yet, but the inability to taper in a reasonable time. And our institution would try to taper about 10% every 5 to 7 days of the steroids and to be off at least down to 10 milligrams of prednisone daily by around day 90. That would be my own management of upfront acute GVHD. Definition of steroid refractory is relevant because if we want to consider alternative therapies, then we need to be sure we're all enrolling the same patients and considering the same outcomes. What are we thinking about these days? I think it's safe to say Ruxolitinib is the main stage for the treatment of steroid refractory acute GVHD. And as an immunologist, when we think of the responses to immunity of adoptive cells, we think of the, again, signal 1, HLA cognate T cell receptor recognition, signal 2 being the cognate co-stimulatory domains, and signal 3 being the activation inflammatory markers within the danger signals of those inflamed tissues. And in this signal 3, where we are mostly is considering JAK-STAT signaling inhibition, and Ruxolitinib with its prior FDA approval in myelofibrosis is the #1 drug that's available. There have been other studies that's going to escape my length of talk today, but suffice to say, I don't think everyone understands that when we talk about JAK-STAT signaling, we are talking about the cascade of oligomeric signaling through signal domains on the surface into the DNA gene transcription promoter pathways. and look at the standard molecules that we're worried about, the cytopenia and what we call blood hormonal markers like erythropoietin, thrombopoietin, or GCSF, which use the oligomeric receptors on the surface of the cell, and as well as other cytokines that are critical, such as IL-2, IL-6. And it's the combinatorial mixing and matching of the JAKs 1 through 3 and STATs similarly that allow us to give clear messages to the nucleus. Now, the drug which has been used most, Ruxolitinib, is predominantly JAK3, JAK1 inhibition. And as we consider how to refine this inhibition, look at all the candidates that are available for testing. REACH1 was an important study, open label, multi-center, phase 2, that was again, conducted early in 2017 and led to the FDA approval of Ruxolitinib for the treatment of steroid-refractory acute GVHD in the States. This was a study for young adults over 12 years of age who had corticosteroid-refractory acute GVHD, and then were able to move forward with enrollment for Ruxolitinib dosed 5 milligrams BID and continued methylprednisolone or Solumedrol. This was continued until response. And so the primary endpoint here is overall response at day 28, measured as, of course, complete and partial responses. And the secondary endpoints that are considered, and I will show, are the non-relapse mortality, the malignancy relapse risks, and of course, the ability to taper the corticosteroids. This trial was able to show a day 28 overall response of 55%. The best overall response at any time point was 73%, and the best overall complete response was 56%. So this is steroid-refractory acute GVHD, and you have a 50% chance of getting a complete response. The overall survival is a bit depressing. At 12 months, you're down to 42%. Median overall survival, 7.6. And here I'm showing the graph from Dr. Jagesia's publication that's comparing the high-risk and low-risk patients treated on this steroid-refractory GVHD. Marked difference expected for patients based on the amount of disease and their risk factors. Now, there was much discussion in the FDA required them to do a second study. REACH2 is a phase 3 randomized, but not blinded study of Ruxolitinib in comparison with the best alternative therapies in patients with steroid-refractory acute GVHD. And here I show the schema provided kindly by Dr. Zeisser and presented last year at TCT. The comparison is 10 milligrams of Ruxolitinib twice a day with the continuation of corticosteroids, and that's a different dose than the last, as well as the alternative therapies. The alternative therapies were a list of 8 different therapies, and not all of them were equally available in every country. And many of these studies were done in Europe, and so mesenchymal stem cells, for example, were an alternative therapy that would not be available in the United States. Again, young adults, age greater than 12, had to have minimum blood parameters in order to be enrolled, and they were, most importantly, as shown here, at day 28, allowed to cross over for a poor response. And 47% of the patients on the BAT arm crossed over to the Ruxolitinib arm, which makes the long-term separation of mortality and durable responses more challenging. The secondary endpoint went out to day 56, and ongoing extension studies will follow this going forward. But here's the comparison. At day 28 on the left and 2 months on the right, the overall response rate has gone from 62% down to 49%, and only 13% of the patients 60 days after treatment remain in a complete response. The best alternative therapy, shown in yellow, is, I think, what we're likely to remember in our own experiences. Very frustrating to be able to treat these challenging patients with steroid-refractory acute GVHD. And by day 56, 21% on the Ruxolitinib were able to stop their steroids. Only 21% is what I should say. And these overall response rates were greatly influenced by their patients crossing over. And so here's my concern. When I look at the day 30 versus day 60, I see the decreasing response. And then when I look at the loss of response on the right, the New England Journal publication makes this look very promising. That is the competing event curve for loss of response, which is, I guess, a reciprocal of durability of response. Looks like it's very strongly supporting the Ruxolitinib. However, it's important to point out that the competing risks were the onset of chronic GVHD or death without progression of acute GVHD. And if you look at what I circle, you see that the censored events for Ruxolitinib are significantly greater than twice as much as on the BAT arm or the control arm. And so while Ruxolitinib discontinued in 72% with 21% due to lack of efficacy, the batch arm had a greater rate of discontinuation. I'm most concerned because of the following in the publication, that is that there's no difference in mortality. Now, we hope that this changes with longer follow-up and that the therapy is more beneficial to the patients, both with non-relapse mortality on the left and overall survival on the right. But this is really the problem, right? The problem is that patients die, and they die of competing risks, acute GVHD, chronic GVHD development, infectious complications, and relapsing of their disease. So this is a problem. The other problem is that there were serious adverse events in 40% of the patients in both arms, and of course, that's what's contributing to this non-relapse mortality. So I point out that that's all available in the New England Journal publication earlier this year. As was pointed out, acute and chronic GVHD are overlapping problems that we used to say was cut off at day 100, but we now recognize that there are features diagnostically that define what is acute and what is chronic GVHD. And so I make sure that I'm emphasizing that when I teach my fellows, that the difference is not the day 100, but rather the patient's presentation. And so chronic GVHD is, in my opinion, the bane of the allogeneic transplant. You did a great job, Dr. Shaheen, of pointing out that, boy, there's tremendous impact in the patient's morbidity, mortality, economic cost, getting patients back to work or to at least an enjoyable lifestyle is the challenge of the chronic GVHD physician. And this incidence of chronic GVHD, it's argued sometimes it's going up because we're doing older patients, and sometimes going down because we're doing more haplo with post-transplant cyclophosphamide. So I can never actually figure it out. I think we'll be dependent on the CIBMTR to tell us what the final recognition and incidence is going to be over the next 5 years. I think that as long as we keep doing more and more transplants with more and more acute GVHD, as you did a great job in pointing out, that we will have more and more chronic graft versus host disease. Unfortunately, 80% of patients with chronic GVHD never come off of their immune suppression. And as you know, the median time and treatment and follow-up is 2 to 3 years. I frequently describe an allogeneic transplant to my patients the following way. I say 7 patients walk into my office. 2 of the 7, or 30%, will never have a problem, never be readmitted. And they will say to me, "Doctor, why did you scare me? That was an easy thing and you saved my life. Thank you very much." I smack them upside their head. I send them out the door and I say, "You have no idea how lucky you are," right? The other 2 patients, one died of relapse and one died of non-relapse mortality before 1 year. So that's 30% of our patients dying before 1 year. And of course, 3 out of the 7, or 45%, half of your patients, are going to be fighting for their lives in your clinic, going through infectious complications, chronic GVHD therapies, and multimodality treatments of their eyes, lungs, and other organ systems. So this is a huge problem. And you've seen these pictures. They're your patients. We score the patients by the NIH consensus criteria. We look across 8 organ systems, and we score based on a 0 through 3 across each organ system, with a composite overall grading based on the numbers of organ systems and the scoring significance. And we think of the patients as either being mild, moderate, or severe, and then we judge their therapy in that sense. So patients with moderate or severe get systemic treatments with mg per kg prednisone, and usually continuation of tacrolimus or cyclosporin if patients are on such calcineurin inhibitors. In fact, most docs will even increase the dosing intensity of these medicines at that time. If patients aren't on those drugs, it's kind of 50-50 as to whether or not physicians will restart those medicines, since, as I'll show you, they've never shown to be beneficial in randomized controlled trials. And the median time to discontinuation is over 2 years. So here are the randomized controlled trials that have been published and reviewed, and as shows on the far right, no significant benefit in any one of these studies. Two of the studies, Koch in 2000 and Carpenter in later 2018, were able to show any significant benefit. So there was nothing shown to be beneficial except upfront corticosteroids. And this remains the place where we'll have to do better. And we hope that an improved understanding of the pathogenesis of chronic GVHD will guide us towards better therapies. When you visit your patient in the office and they say, how am I doing? And they start to develop those mouth sores, those dry eyes, those AST, ALT elevations, you quickly in your mind are doing this calculation. You may not think of it in this formal sense, but you should. Again, looking at, what was their risk features of their disease coming in, their type of transplant, did they have acute GVHD, and all these things listed here, allowing us to make a judgment of what the patient can expect for the incidence of chronic GVHD success. Now, what are the therapies for second-line chronic GVHD? Well, there are a myriad of unproven therapies and one that's FDA approved. So after corticosteroids, there's no current consensus on the optimal treatment choice, except Ibrutinib is the FDA approved for steroid-refractory chronic GVHD. And as you know, I've been involved in its development, so I'll go through that in some detail. Many retrospective studies suggest initial high responses that, once we do well-powered studies and control for the disease, have been shown to be not beneficial. And so frequently, the treatment choice is based on the patient and the physician having a conversation. The physician's experience plays a big role. The ease of use in the States is important, and the need for monitoring or the risk of toxicity needs to be considered. And extracorporeal photopheresis is probably the least convenient of the therapies that we do in the United States, but has been shown to be beneficial, especially in sclerotic GVHD. So I start here with Dr. Jagaja's recent publication, where we show that there is a significant overall response benefit in the 50-some patients being treated on this randomized study. These patients had blinded assessments, and they show on the right that most of the benefit was obtained in the moderate chronic GVHD patients, but not the severe. And I think it'll be important to follow these patients going forward with longer follow-up. Mary Flowers has shown a recent, an older 2008 publication with benefit in the area of the involved skin at the treatment of ECP and chronic GVHD sclerotic skin changes as well. I certainly reach for ECP when I have patients in their later stages of sclerotic skin GVHD, mostly because I think that the concern for infectious complications is lower. The thing that bugs me most about ECP is not really knowing what the pathogenic mechanism is that it's actually interfering with, since it works through a relatively small number of cells, and we've never really convinced ourselves of which Treg or B cell or activation or APC is being most immediately affected. Now, my interest has been for the last 20 years in B cells, allogeneic B cells that are transferred from the donor into the recipient. And as you know, there have been many studies early on showing the Rituximab benefit in the established steroid-refractory chronic GVHD. My colleague Stephanie Sarantopoulos has done a fantastic job understanding the underlying science of the B cell activating factor, BAFF, and its ability to be measured in patients and shown to be highly associated with chronic GVHD risk and development. And we know that the delay in B cell reconstitution is likewise associated with the problem of chronic GVHD. A few of us have done Rituximab prophylaxis studies, and Dr. Moti, as well as Dr. Cutler and Dr. Arai, have published these phase 2 studies. I want to make a big shout out. Dr. Cutler and I have a 200-patient obinutuzumab versus placebo randomized controlled trial going at this point in 5 institutions, and over 200 patients will be enrolled as a prophylaxis prevention of chronic GVHD. And while we don't have a fancy drug company company to sponsor our study at this point, it has huge implications for the prevention of chronic GVHD. This arm of development of the immune phenotype of B cells, and in particular the red arm showing the CD20 expression, explains why this makes such a nice target. The hematopoietic progenitor cells and the common lymphoid progenitor cells in the bone marrow space do not express the target of CD20, nor do the plasma cells making the established infection antibodies that are protecting the patient. And so what we're doing when we're depleting with Rituximab or obinutuzumab or an anti-20 antibody is removing the active B cells, the pre-germinal center B cells, and the memory B cells that are causing this alloreactive B cell response, but we're protecting the ability to reconstitute after the Rituximab clears, or we also maintain the antibodies to protect the patients from infection. And so this Rituximab hypothesis made this testing very safe. And my own work, looking at sex mismatch transplantation, where males with females, as shown on the left, have this higher risk of graft versus host disease, both acute and chronic, but predominantly chronic GVHD, as well as a decreased risk of the relapse. And this is pointing out the graft versus tumor allogeneic benefit. And so in my labs, we developed assays measuring these HY antibody responses in hundreds. In fact, we've reconstituted this experiment using blinded samples provided by the CIBMTR most recently, earlier this year, published in Hematologica. So it's not really at this point, I feel very confident telling you we can see that antibodies that are developing from the donor cells at 3 months predicting of what will happen in chronic graft versus host disease over the next 1 year. So we are recognizing the benefit of targeting allogeneic B cells in the prevention and management of chronic GVHD. And it provides a safer way to treat GVHD that leaves the T cell anti-tumor, anti-infection intact. And so Cutler and I did this study in 2004. It was a small study of 21 patients, ultimately stretched out to 34 patients. And like I said, all patients have roughly a 50% response rate, here shown 40%. And but does it actually persist over time? And the answer was no, that many patients will have their disease recur. And those alloreactive B cells are not completely eradicated by patients with chronic GVHD using rituximab. This is the same study, and then in comparison on the right, shown with other phase 2 studies. And the size of the box gives you a size of the significance of the studies that are being reported. You can see overall benefits of around 60%, and the individual summary estimates are never supported in a randomized study thus far. So how would we get a more potent B cell response? And of course, you know the answer. It's the inhibition through a covalent, irreversible inhibition of the Brurton tyrosine kinase molecule, BTK. And with the development of Ibrutinib in 2013 for mantle cell, 2014 for chronic lymphocytic leukemia, the drug became available, and we started a investigation, the test of this drug in the treatment of steroid-refractory chronic GVHD. And here these patients had 25% of their body surface area with an erythematous rash or a CIBMTR mouth score of greater than 4 at the time of enrollment. And the patients had either steroid-dependent or steroid-refractory chronic GVHD and had not gotten more than 4 prior lines of therapy. It was a small study. 42 patients were enrolled at 7 centers, and the dose of the Ibrutinib was 420 milligrams, which was well tolerated in the first 6 patients of the phase 1 run-in and maintained as the recommended phase 2 dose in the study of 42 patients. The endpoint was chronic GVHD response or unacceptable toxicity, and the other exploratory endpoints looked into the correlative scientific measurements, but patient outcomes, the Lee symptom score, the change in steroid dosing, and the safety were critical to the FDA's approval of this agent. There were 42 patients, and 14 of these patients discontinued the drug relatively quickly for what was perceived to be adverse events and patient intolerance. And this is very much a site-specific phenomena. In my experience, I found that even when patients had difficulty with cramps, ecchymoses, bleeding, nausea, vomiting, or stomatitis, that a drug holiday was very effective. And you can see on this slide that only 2 patients actually came off drug for disease progression. So this became a study of 42, where 14 came off study, and the remaining 2/3 of the patients were evaluated for response. And as I just said, the 20% or greater side effects are fatigue, diarrhea, cramps, nausea, and tendency to bruise. And you've seen this presented as a late breaker abstract in 2016, a Blood publication in 2017, and even updated by Dr. Ned Waller in 2019. So this data is well known to this community. There were 2 patients in the 42 treated who died of infectious complications, which I think we agree would be expected in this heavily treated chronic GVHD patient population. And overall, the complete and overall response rates are shown on this graph. Overall response rates of 67%. Really remarkable considering the other third came off study for toxicity. So everybody who essentially stayed on study had a response. And again, what I'm showing you is the complete response rates were increasing at 21% in year 1 and 33% in year 2, as I'll show on the next slide. 5 patients ultimately discontinued before their responses could be assessed, and only, as I said, 2 patients had progressive disease. So here's the FDA required second-year follow-up that Dr. Waller has now published as a letter, and showing that the overall response rates persisted, that the conversion of partial response to complete response occurred in 3 additional patients, and no patients had progression in that second year of therapy. Likewise, there were 2 additional SAEs in the second year for infection, and no other significant AEs identified, and patients have gone on to obtain benefit from this therapy for years. And we can tell this most clearly by the patient and physician reported symptom scores, and also by biomarkers that again, I'll refer you to the paper. I do want to show that in the first column, that's the infusion, that those are the measurements of the blood serum chemokines and cytokines prior to Ibrutinib on day 1. And 4 hours later is the second column. Likewise, day 2 and then day 8. And so the effect of Ibrutinib on the cytokines and on the mediators of immunity is immediately obvious within a 4-hour shift after the infusion of the drug. And then you can see on the right, as patients become steady state, that those cytokines have become stable and persistent. And so we think this biomarker shows significant reductions in the plasma factors that are markers of inflammation and lymphocyte activation. And these reductions are persistent and measurable. And I think that our studies here, which looked at the depletion of pre-germinal center B cells, as shown to be IgD38 positive. Those are activated B cells before they go into the lymph node germinal center. And on the right, in our CYTOF analysis of, again, 15 patients through 90 days, looking at the in the red, pre-germinal center, and on the black, the memory B cell, shows this differential depletion of the pre-germinal center activated B cells that are present on the top row, and then depleted in the red circle on the bottom row, where the memory B cells that are present are not depleted, and will be available to the patient's ongoing immune benefit over the next years and follow up for reconstitution of their chronic GVHD treatment. On the far left, I show a significant change in these pre-germinal center B cells across all patients treated on this study. And it leads us to a model summary of the Ibrutinib benefit. And here we're schematically showing on the left the B cells, in the center the T follicular helper cells and the activated BTK positive B cells. And on the far right, we're showing that the cytotoxic T cells are protected, as are the regulatory T cells. And so, as read by the bullets on the right, Ibrutinib selectively depletes these activated pre-germinal center B cells and depletes the follicular helper T cells marked by the BCL6 CD185 positive, that's TBET. But the Ibrutinib preserves Th1 TBET positive killing cells, cytotoxic CD8 cells, and Treg cells. And so that overexpression of resting lymphocyte kinase that rescues the effect of Ibrutinib provides a selective benefit, depleting the alloreactive contributing to chronic GVHD, but maintaining the T cells that are necessary for viral and graft versus tumor benefit. And we're testing this in a randomized placebo-controlled 186, I think it's 189 actually, patient study called Integrate. It has been an international study. I don't know if any of the patients are treated in the Gulf. This accrued over 18 months ago. The follow-up is being organized and will be presented at EHA in Vienna in June of 2021. I am not able to speak to the results, but simply stated the results will be presented in about 6 months. This is an important study because it's the treatment of new onset chronic GVHD with mg/kg steroids plus or minus Ibrutinib or placebo. And again, that placebo is critical. One of the criticisms I will have of many of the current studies is that they are not placebo controlled, and patient and physician knowledge of what they're receiving influences their treatment plans. So here's the study arm showing the randomized controlled trials of patients with treatment of new drugs in chronic GVHD. These are important studies. I just mentioned Integrate, and I'm going to show you Reach 3 in a second, and I will tell you Progress 2 is anticipated this year to be presented. I already showed this. And so here is slides provided kindly by Dr. Robert Zeisser that were presented last week at ASH, and this is my summary of Ruxolitinib's effect through the STAT3 and STAT1 pathways that are impacting on the left the interleukin 22 and Th17 cells, and on the right interfering with interferon gamma and IL-2. And so this combined process is able to dumb down T cells and impact, as we showed, acute GVHD. What's the benefit in chronic GVHD? Well, Reach 3 is a very large study of 350 patients that were age 12 or higher who lacked response for mg/kg steroids after 1 week or were dependent on ongoing steroids as outlined in the left. The patients were randomized, but not placebo-controlled, and you can see that the best alternative therapies, again, attached a list as shown in a very small print that the physicians could choose from. And importantly, it's patients had received prior Ibrutinib in many of the patients. The dose was Ruxolitinib 10 milligrams twice a day, and patients were, of course, managed on continuing doses of steroids plus or minus their calcineurin inhibitors if the physicians had them on that at that point. After, again, 6 months, patients were allowed to cross over. So week 24 was the primary evaluation, and secondary evaluation was going to be at 1 year. And you can see that the endpoint was overall response rate. And so what did we learn? Overall response is 49% in the Ruxolitinib arm, 25% in the alternative therapy, with very few complete responses. The slides will be made available to you, and you've seen this at ASH. So let me move to the next slide, because I think it's very interesting to see that yellow dip that's occurring at 6 months, and that's the crossover. And so when patients were allowed to cross over, they did. 30% of the patients crossed over. And again, this is going to make long-term follow-up challenging. But perhaps more challenging is the fact that there was no blinding. So we have good evidence here that there is a benefit using Ruxolitinib, that the here shown as failure-free survival at week 24 is significant, that the benefit of failure-free survival is that the patient has not started on a new therapy, has not relapsed, has not died. And as I showed on the last slide, the overall response rate was 50% in the Ruxolitinib arm with 6.7% complete response. So this is exciting. This is probably going to warrant support from the FDA and the other agencies to provide this drug going forward. But I will say that we don't have enough follow-up to fully understand what the risks of infectious disease and non-relapse mortality will be with interferon IL-2 inhibition in this patient population at high risk for infection. And so those numbers will need to be followed, especially in the peer-reviewed final publication of this. Dr. Cutler provided me the Rockstar studies as well that he presented on Sunday morning. The Rockstar is a follow-up analysis of the KD025 drug, which is a ROCK2 inhibitor, and it's a phase 2 randomized by dose in patients with steroid-refractory chronic GVHD. Now, ROCK is a little bit different and I think somewhat more exciting than for chronic GVHD because it hits two mechanisms that are important in pathogenesis. One is the inhibition here shown, the immune response, that it inhibits the JAK molecules and again, goes through especially JAK3, STAT5 with the IL-10 pathway, but also inhibits through, as I'll show in a second, a polymerization of actin. But you note on this study that you're leaving the T follicular helper Th17 cells intact on the left. You're leaving IL-17, IL-21 cells intact, and you're, again, interfering on the right side through the, again, STAT5 pathway predominantly. So you end up downregulating pro-inflammatory cells and you increase Treg cells. I like this schema. I hope it's true that we're inhibiting actin in the myofibroblast cells directly, and that this ROCK2 inhibition through the serine kinase is able to really prevent the fibrosis and even abrogate established fibrosis in the tissues themselves. Now, this is a orally available and ROCK2 selective inhibitor. And the drug study was performed with 2 arms, dosing 200 milligrams either once a day or twice a day in actually 66 patients per arm. Again, young adults, ages 12 or higher, who had had multiple lines of systemic therapy for chronic GVHD. They were stratified by prior Ibrutinib and severity of chronic GVHD. And the safety review of this was very favorable. Most interestingly, there were about 20% of patients who had fatigue, diarrhea, nausea, edema, or interestingly, LFT abnormalities, which is a bit unique for this therapy. And again, the overall response rate is what was going to be reported out as the primary. So here's the overall response rate, primary endpoint, showing really no difference at 12 months comparing the 2 dose arms. And the belumosudil is the name that's going to be used, belumosudil. And there were only 7 patients who achieved a CR in all affected organs. And this benefit, though, of partial responses was seen relatively immediately with 4 weeks response rates. And the significance of dose is not evident. And it'll be interesting to see what they go forward with. I presume once-a-day dosing will be what they use going forward. Here we see the event-free survival presented in a manner that we can attribute the fall off. And the dark gray on the bottom is the physician's discretion to change therapy. And on the top is the relapse, and the red is the patient's death rate. At 12 months, there's a 58% persistence of failure-free survival. And this is very favorable in comparison with all other therapies as well. And we'll be looking at the benefit going forward. Again, this is not a blinded study, and there's no placebo, and this was not randomized against an alternative therapy. So this is what the patients received. I will say I've seen some of my own patients on this therapy, and I have seen some dramatic sclerodermatous changes in responses. And the longer the patients stay on the therapy, they seem to continue to benefit. So I do have a lot of excitement. I know that Dr. Cutler is bringing that therapy forward into bronchiolitis obliterans as a phase 1, phase 2 institutional study as well. And of course, bronchiolitis or lung GVHD is one of our biggest problems. And this is my wrap up. Dr. McDonald, Carrie has presided this wonderful review from 2017 Blood. Beautiful color here where we go through a 3-phase component of chronic GVHD. And here I'm breaking it out. That phase 1, there's in the bag T cells that arrive from the donor. They're alloreactive, and they also impact the innate immune responses. These alloreactives are causing problems in the damage of thymus, bone marrow, follicular germinal centers in the alloreactive path, but also conditioning and infection is contributing to that first phase of alloreactivity and innate damage. In the second phase, this is where my work is focused, the cooperative B-cell, T-cell interactions in germinal centers are amplifying the immune response, especially those dysregulated alloreactive responses that are resulting in stage 1. The dysregulation of the T follicular helper and B cells are leading to the overproduction of allogeneic antibodies, T cells being polarized to Th17 phenotypes. And of course, what we're really learning about here in phase 3 is the peripheral activation of the macrophages and the damage through fibrosis, as well as persistent immune reconstitution damage in our target organs, especially skin and lungs. And the overproduction of the pro-inflammatory cytokines, IL-17, 21, interferon gamma, and these alloantibodies are continuing to drive the macrophage and the sclerotic damage. So it's really fantastic to hear that Rockstar belumosudil or KD025 are going to have some benefit in that end organ damage. And then I want to point out a study that I didn't make a slide for, but CF1 studies done at Minnesota by Mukta Arora, presented at Sunday's ASH meeting, showed early promise. And I will say I'm very excited to see another targeting molecule specifically of the macrophage and damaging and trying to remove this sclerosis, long-term peripheral blood damage. And so in summary, the hematopoietic stem cell is amazing, right? It reconstitutes blood, and the immunologic response is able to eradicate blood cancers, but the patients have to reconstitute their immune systems, and they have to avoid GVHD. And so when I teach acute GVHDs, the alloreactive T cells in the bag, and Ruxolitinib is FDA approved as our treatment for steroid-refractory acute GVHD. It's important to use 2 mg per kg in the therapy. And in chronic GVHD, we have one approved agent. It's Ibrutinib that is FDA approved for the treatment of chronic GVHD after 1 or more lines of therapy. It irreversibly inhibits the activated B cells and inhibits T follicular helper cells, and it has impact that is really important in that second phase of chronic GVHD as I think about it. I point out the I hope exciting results of the randomized controlled trial called Integrate that will compare Ibrutinib versus placebo in patients with new onset chronic GVHD receiving steroids. And that'll be presented at EHA, June of 2021. There are promising GVHD drugs that I suspect will be considered by the agency. And most importantly, after ASH of this year is Ruxolitinib. That is going to be through the REACH3 study with the overall response rate at week 24 being 50% versus 25%. And the CADM drug, KD025, belumosudil, which is showing overall response rate of 70%. And was really dose independent, whether it was once a day or twice a day. And again, I'm going to plug Dr. Cutler's and my randomized controlled trial. And I think it's open in Minnesota, if I'm not, in Mayo, if I'm not mistaken now, Shahrukh, where we're giving obinutuzumab prophylaxis 3, 6, 9, and 12 months as a prevention of chronic GVHD. And again, not as exciting because it's an old drug, but would be wonderful to prevent chronic GVHD. That is the end of my presentation. I apologize for going over time. Thank you.
Thank you. Thank you very much. We enjoy it. It's very comprehensive, elegant, and up-to-date. There is up-to-date slides about the ASH last week, and we enjoy it. I hope you will stay beyond 9 to answer some question if you can.
Absolutely. I'll stay for questions, and also make the comment that the slides are available to distribute through your society, okay?
Perfect. Thank you very much. Very generous from you. And now we will go with our colleague, speaker, Dr. Shahrukh Hashmi, who will speak about one of the challenge, which is really a staging and the diagnostic challenge. Please, Dr. Shahrukh, proceed. Dr. David, can you please stop sharing? And
I apologize. Thank you very much.
Perfect. And now, yes, we can see your slides, Dr. Shahrukh. Go ahead.
Well, thank you very much. Can you hear me?
Yes, we can. If you increase your voice a little bit.
Okay. Thank you very much for having me, and I thank the SSBD, and the hosts, and the organizers for this meeting. A pleasure to be here, and obviously I have very little to offer after Dr. Mikla's talk, and I'm delighted to actually be up to date after listening to this talk. And on purpose, I didn't put a lot of pathophysiology because I knew David was going to talk about it. I have no relevant disclosures to this talk. I've received honorariums for various ad boards and others as listed here. So today I'm going to make it a very clinical talk to focus on differential diagnoses, because I was asked by the organizers to focus on the post-allograft conditions which make it hard to diagnose graft versus host disease. So this is an example of a patient a month after the allograft post-haploidentical transplant developed significant rash. It was painful as well. And the question is, what's the diagnosis?
Dr. Shahrukh, there is a comment about the voice. If you can please hold the mic near your, thank you very much.
Sure. Can you hear me better?
Yeah, now is better. Yes, sure.
Okay, thank you. I will just hold it here because I want to make sure that the audience can hear the mic. Thank you. So this is one of the cases of vasculitis, in fact, rather than acute graft versus host disease. And some of the times, well, it's very hard to diagnose a condition, and you would think that it's IgA vasculitis versus other drug rashes versus graft versus host disease. It just tells you the importance of having a skin biopsy after allograft in order to diagnose a condition. This is from Strategic Market Intelligence Report, one of the data looking at the future of acute GVHD and chronic GVHD. This is focusing on different countries. As you can see, the cases will rise likely despite the haploidentical and post-transplant side coming in because of rise of many factors, increased donor availability, increase in transplant, better conditioning regimens, and obviously use of peripheral blood stem cells for heme malignancies. So the burden is going to be significant, and a lot of people who are on the call who do not do GVHD daily will be seeing patients of graft versus host disease one way or the other in their careers. So it's important to know about this disease. So this slide I usually put out to teach residents and fellows about the graft versus host disease types. Well, the classic acute GVHD and the late onset GVHDs are slightly different in presentations. It typically presents within 100 days, but as Dr. Shaheen had mentioned, in 2005, the criteria was changed. There was no day 100 mark. And then obviously 2014 came with overlap syndrome, better definitions of that. And then, well, the bad news is it's changing again this year and at the NIH. And I think next year we're going to have a new staging system for the chronic graft versus host disease. But the classic acute typically presents very early. And a lot of damage happens within the conditioning. There's a persistent recurrent late onset that it can happen later on. It doesn't have to be within 100 days. And this is like typically a diarrhea, which keeps on happening again and again. The classic chronic graft versus host disease can present anytime. We've seen that at day 90. We've seen it at 6 months. What is the peak time of having chronic graft versus host disease according to CIBMTR data? 5.5 months. And that's the typical time when for heme malignancies, a lot of people have tapered down the tacro to minimal tacrocyclosporin. Overlap syndrome became very important in the NIH criteria. It can present any time. And if you even have one feature of chronic graft versus host disease, and rest of them are looking like acute GVHD, like the mouth and skin, you would label that as acute overlap syndrome. It's been refined and redefined multiple times. Hyperacute GVHD, we don't see it, but mismatch cases used to happen in the past. And we used to see a lot of it, but no longer we see that in the current era of 10 by 10 matches, as well as chords and haplos.
Dr. Shahrukh, sorry, again, please close to the mic. Thank you. Closer to
Okay. Is it better now?
Yes, yes, please. Keep it this way. Thank you.
Okay. Thank you very much. Apologize for that. Autologous GVHD and transfusion-associated are rare. I'm not going to talk about those today. A solid organ transplant, intestinal, hepatic, and are more common solid organs after which we see the GVHD. And we have seen a lot of patients. We've done consults for these patients, and this is pretty severe because it affects the bone marrow eventually, like the transfusion-associated GVHD. And then you've got IPEX syndrome and others, which mimic autoimmune conditions. So what are the risks for this? When you're looking at the GVHD, is it truly GVHD or other conditions? Obviously, HLA disparity is the number one factor. The donor age is an important one that's not here, but recent studies by Bronwyn Shaw and many others have clearly shown that donor age is important. Gender, female going into male, very big factor. Intensity is important as well. And in the past, a full dose TBI versus reduced dose TBI, a full dose would damage a lot more GI tract compared to reduced intensity. Acute GVHD prophylactic regimen is the key here. And Dr. Miklas mentioned the 1301 study, and obviously before that was 1203's TTN study. But now we have the bigger study of looking at the post-transplant Cy versus TAC and methotrexate, which is 1703 study of the BMT-CTN, which is ongoing. And recently it has been merged with the microbiome study by Ami Bhatt and other colleagues as well. The source of the graft, cords, haplos, mud, MRD. We've got many sources today, and suffice to say that post-transplant Cy compared to a 10 by 10 mud has shown almost equivalent results as far as the survival is concerned in studies that were published from CIBMTR by Stephen, by Shiaria, as well as Mehdi Hamdani for leukemia and lymphomas. But the GVHD was much less with the post-transplant Cy approach. The bone marrow versus peripheral blood stem cells, there was no difference in acute GVHD statistically significant effect between the two sources in BMT-CTN 0201 when Claudio Anicetti had presented that at ASH as well as in the journal paper. However, the chronic GVHD was slightly less with the bone marrow source compared to the peripheral blood. However, the peripheral blood had a better result as far as graft and engraftment was concerned. So this diagram we see a lot, and this was about 3 decades ago when Jamie Ferrara was in Michigan. But obviously this was a very elegant model for initially murine models and then the human model for acute graft versus host disease, but mainly applies to pediatric. And I'll tell you why, because my thymus is very, very small. And as the age progresses, the thymus really regresses. A lot of pathways of Th17 and interleukins are very different. And the conditioning does damage the thymus a lot in pediatric studies. Even this week, there's an article in Nature Reviews of Immunology of the Tregs, NKTs, and gamma delta cells, maturation from the thymus. So you can put the thymus immunology and think of the pathways that can be affected in a pediatric population versus adult. But suffice to say that the interplay between Tregs and Tcons is critically important in chronic GVHD. But now we have a lot more data that Dr. Miklas had showed, but also TLRs and many other things that we know now. Well, the IBMTR Glucksberg criteria is pretty old. Well, it's still being used in a lot of trials, and it's still being used for clinical assessments. And it was made a long time ago. People have tried to refine and redefine this criteria. But this is one of the fundamental staging areas that one must consider clinically off trial at the moment until newer criteria get validated across the world. It is important to note that John Levine and colleagues had started collecting biomarkers. At that time, Sophie Pakshizny had also published a New England Journal paper on the omics approach towards biomarkers for prediction of the prognosis of acute GVHD. But the MAGIC consortium really worked hard to look into the prediction of non-relapse mortality and survival based on the biomarker approach for acute graft versus host disease. And we from Mayo Clinic had contributed a lot of specimens as well, and were the original 4 centers for this MAGIC study. And this paper of the scoring called Ann Arbor staging system had been published already in 2015 in Lancet by John Levine and colleagues. And then obviously there were a couple more papers, and this on the right-hand side you can see the graph that was published recently by John and other colleagues. There have been studies based on this as well, including many new novel agents that if the biomarker studies are indicating a higher risk of acute GVHD, then you would treat early rather than waiting for symptoms to appear. And Marky McMillan, colleagues from Minnesota, had shown the scoring system for acute GVHD. And I'm not going to go into detail because Dr. Miklas had showed 2 slides in this already. So there's a high risk and standard risk, clear differences in the risk of mortality. This is on relapse mortality post-allograft. And this is being validated recently. This has been actually published in Hematologica as well. So it's very likely that this is going to take a big role in clinical trials for acute graft-versus-host disease. But the chronic one is something we really need to focus on because there are distinctive signs in this figure that you can see on the left-hand side. They're distinctive on the right-hand side and diagnostic on the left. Because if you have any of the diagnostic sign, you have chronic GVHD. You don't need a biopsy necessarily. And I do not do biopsies in my GVHD clinic because when I see fasciitis, a new fasciitis developing in a post-allogeneic transplant patient, I know that's chronic GVHD. I've got to treat that early. I've got to treat that aggressively with 1 mg per kg of steroids because this is chronic GVHD and it will progress from one organ to another. And that's actually a very challenging thing because sometimes we see it just starting in the ocular eyes or just starting in the skin or vaginal tract and it goes all over. And different organs get involved. And Madan Jagasi actually recently published a paper, actually a couple of years ago in Hematologica, looking at the artificial intelligence approaches of predicting different groups and subgroups of graft-versus-host disease at diagnoses, indicating that some groups have a very high risk of mortality and morbidity compared to the other groups. It's kind of hard to predict which groups are going to filter out into a good prognosis versus bad prognosis. But this is something that is in our clinics, in BMT clinics, and this should be. If you are going to be doing allogeneic transplant, all the physicians taking care of this, all the trainees must know this, and they should grade and score this, chronic GVHD. And this paper should be present everywhere, even with the nurses. And I have this with my nurses. Even today, I had a GVHD clinic. And I'm seeing the patients coming back to UA after transplant, and we are doing this. My nurse and I are doing this, and we can finish the whole thing within 5 minutes with the examinations because you get used to it, because you know the scoring actually of the eyes, the GI tract, the liver, the skin, and then you can actually treat the patients, because if I've got a score of 11 and I'm treating with Ruxolitinib or Ibrutinib for chronic GVHD, I need to know actually if this is truly improving objectively or not. Obviously, subjective is very important as well. Well, this patient did not have acute GVHD. In fact, he had a skin rash because of toxic epidermolysis necrosis. In fact, he had a lot of TEN and had to be treated with steroids and other medications. But this is a consult I got from India, and this patient, they were thinking has chronic graft-versus-host disease because vitiligo is a very known complication. But this happened within 100 days. And when we got all the history and look at the whole skin, in fact, this was a very rare presentation of acute GVHD. Versus overlap syndrome, but obviously there were no other features. But suffice to say, vitiligo has been related to chronic GVHD, not acute, in many of the publications that you have seen in JAMA Dermatology and other cases. But in some cases, you really need to figure out, you really need a biopsy to think that it's truly overlap syndrome, or is it a very distinct manifestation of acute graft-versus-host disease. This was a rare exception. But the problem is that a lot of viral infections can coexist.
Again, please, near the mic. Thank you very much.
Okay. And then the allergies can happen as well. They can resemble acute graft-versus-host disease. We have published a few papers on the proteomic approaches of of the acute GVHD. Dr. Lehman and I work in this area at Mayo Clinic. This is one of the papers in which we looked in these different histology factors like spongiosis and eosinophils, which were significantly lower in the GVHD compared to the drug hypersensitivity reaction. So you must get a biopsy in the cases of acute graft versus host disease suspicion. For chronic, no, but acute, yes, because you got to treat it, and you got to treat it well. You're not going to treat with second-line agents unless you have a confirmed acute graft versus host disease. The GVHD of the GI tract is very, very tricky because it can be mucositis very early on. But after that, the first 2 weeks, it could be graft versus host disease. It could be GVHD. Acute GVHD. It could be drug-induced or infections. The problem is the C. diff and GVHD couldn't coexist. You will see a lot of papers in which C. diff happened and then the GVHD follows as well. That is a trigger for graft versus host disease. So you need to have a high suspicion of this. Same thing with liver. Drugs, infections, SOS, which is called VOD in the past, and GVHD itself. This is a case in which you're looking at the, on the left-hand column, the endoscopy report in which there's a lot of ulceration. But on the right-hand column, you're looking at the apoptotic bodies. These are the green arrows, and the black arrows are showing damaged crypts, which can happen with CMV as well. And you can then stain it for CMV, and if it's negative, it would kind of rule out CMV, although it depends on how many biopsies you're taking and eye of the beholder. But this was a case of mycophenolate-induced colitis, not graft versus host disease, and not CMV. So you have to think of this. You've got to tell the endoscopist, you've got to do multiple biopsies, got to tell the pathologist, you've got to look at all the features and all the specimens, and you've got to tell them you got to stain all the for CMV from all of them, in fact. The lung symptoms are one of the most tricky ones because you can have BOS, you can have a restrictive disease, combination of above, plus infections at the same time. And this is not uncommon because we've got patients who've received a lot of ABVD for lymphomas, for Hodgkin lymphoma, then relapse and autologous transplant, Rituximab, and then you give massive beam, which is carmazine. These medications all cause a lot of fibrosis. I mean, you got to think about all the history, the risk factors, exposures, and the outcomes, and then think, what is it? And you've got to have a bronch actually to diagnose this condition. Otherwise, it could be very challenging. And one of the papers that we published with my brilliant mentor in Saudi Arabia, Anas Hakim, and Ken Cook and Steve Pavlitic and others helped out was looking at different modalities which can help us in diagnosing the lung GVHD across the world, because a lot of people do not have sophisticated HRCTs, and people don't even afford them for like 3 years out of transplant. So these are other modalities that can help you in surveillance of lung GVHD. It's one of the papers we published with Nathan Treister and Dana-Farber in oral diseases. And these are essentially all my patients from Riyadh, in which we looked into the manifestations of chronic GVHD, including the picture of the lips where they have a lot of discoloration, hyperpigmentation, erosions, and a scurvy type picture as well. In the neck, you can see sclerosis and morphea, which is a very diagnostic manifestation of chronic GVHD. And the picture in the B is a very classic wrist deformation from one of my patients with chronic GVHD. Ocular toxicities, we published 2 papers from CIBMTR and EBMT, looking at differential diagnoses as well as complications happening and how to treat them. And suffice to say, there's a list of drugs. This is a table 3 of the paper. It has a whole list of medications that can cause eye problems. And you would think that ocular GVHD is the only cause, and that's incorrect because there's many other drugs that can cause dry eyes in allogeneic transplant patients. So take a look into this, take a look at the exposures that they've had, the allergies that they have, as well as what treatments they're having, and then decide about GVHD. Similarly, myositis is another one. and this is one of the studies we did at Mayo Clinic a long time ago with 68 patients. And it is kind of difficult sometimes to diagnose it. And the EMG itself alone can be non-diagnostic because that can happen because of multiple things in the past, including chemotherapy. So you got to look at the antibodies, enzymes, muscle biopsy as well in some patients, and a combination of imaging as well. So suffice to say, sometimes it becomes very hard. And I think it's good to seek help, but it's got to be a multidisciplinary clinic with a physical therapist, ophthalmologist, pulmonologist, dermatologist, psychologist, gynecologist, and others who are going to help us diagnose graft versus host disease in an appropriate fashion and timely fashion so we can treat it. So I'm going to go over it. I'm going to summarize this in the interest of time. That you've got to have a high probability of suspicion for early diagnoses. Acute GVHD does require biopsy in most of the cases. And the earlier, I mean, if you're going to delay the biopsy, a lot of damage will happen. And this is even true for the liver. If you can't get the percutaneous, which you can't in most of the cases, you've got to get the transjugular very early. That's why you need to have a very good radiology department when you're doing allogeneic transplant. Chronic GVHD of the skin and musculoskeletal, and some of them, like oral, do not require a biopsy necessarily. The BOS and the liver are the trickiest, and those are the ones that I see in my GVHD clinic are end stage. And the only treatment that works for them for cure is a transplant, a lung transplant and a liver transplant. I'm very aggressive in at least approaching the teams for that because none of the medications are curative. I mean, they can help a little bit, they can buy time. At the end of the day, transplant is the only thing that's going to help. And when in doubt, treat as graft versus host disease, like 2 mg per kg per day for acute with steroids and 1 mg per kg per day for chronic GVHD. Multidisciplinary clinic is the optimum approach. Clinical trials should be the first line of management. I've been a big fan of this clinical trials. I've done many trials as a PI on chronic GVHD. But if I don't have a trial in my department, in my institution, I would strongly encourage you to send to another institution, put down the institutional egos, and send the patient somewhere for clinical trials because there's a lot of work to be done. With that, I'm going to thank everybody and think of research, creativity, and innovation. And this pertains more to graft versus host disease than perhaps any other disease that I know of. Thank you very much.
Thank you. Thank you, Dr. Shahrukh, for the nice presentation. And now we will open the floor for questions. And first question is from Dr. Panayotis from King Fahad Specialist Hospital in Dammam. Question to Dr. David. In responders after Ibrutinib treatment for steroid-refractory chronic GVHD, what is the recommended period for treatment? Do you suggest tapering or discontinue or abrupt discontinuation of Ibrutinib?
Well, that's an excellent question. Is my audio on?
Yes, we can hear you.
Good.
Yes.
That's an excellent question. It wasn't answered by the 1129 study, and we hope to gain more information from the randomized controlled trial as to what the optimal treatment period for Ibrutinib would be. The pathogenesis suggests that this would not be necessary to continue forever. It's really interfering in that second phase alloreactive and dysregulated immune responses. And because it's inhibiting through again, irreversible inhibition of the alloreactive B and T follicular helper cells, this should be, I would say, a period of time. My practice is to not try to extend Ibrutinib beyond a year. Once I get beyond a year, I start to think I'm not doing anything that is impacting that portion of the alloreactive pathway. And this is where, again, I'm excited about the opportunity to interact more with the sclerotic phases, the macrophage acting drugs, and the potentially CSF1 drug as well, the colony stimulating factor 1. So I would also, in my, since I have the pulpit for a moment, remind people that ibrutinib does have side effects, right? Stomatitis and cramps and muscles, problems with nausea. And it's really important to make sure you're giving the right dose of ibrutinib. And that frequently means to carefully consider the P450 system. And so if you're on a posaconazole, voriconazole, P450 inhibitor, you really should be taking 140 milligrams of ibrutinib and not more. And if you're seeing patients with stomatitis or worsening mouth problems, stop the drug for 1 or 2 weeks, see if the patient's symptoms improve, suggesting that this is a drug toxicity, and then restart at a lower dose or even an every other day dose. Because again, it's important to recognize that these inhibit the B cells irreversibly, and that you don't have to worry about the patient being on drug every single day. It's a beautiful dosing algorithm for this drug. This is very different than giving steroids or calcineurin inhibitors.
And when you decide, like if, let's say beyond 1 year and you want to stop it, you taper it or you
No,
just
so
stop it?
again, there's no reason to taper for the exact same reason. You're either inhibiting or you're not inhibiting. It's either all on or it's all off. And so there's no reason to be tapering. I do not taper.
They notice in they have 11 patients on ibrutinib, and they notice that 40% develop invasive fungal infection. Do you notice the same in your cohort?
So I will say that randomized controlled trials have not shown a great increase in the risk of upfront fungal infections. This will be a very important aspect of the randomized study that I can't speak to, because it is both a safety as well as efficacy study. And the 2-arm study will allow us to compare that risk of fungal infections across the 2 arms in the new onset, never treated previously chronic GVHD patient cohort. This will be a very powerful insight into the risks of natural course history of 200 patients with new onset chronic GVHD that have been carefully monitored ad nauseum, I would say, by as only a good pharma company can do. So I always place patients on mold protection. I call it the triple P, right? It's prednisone, Protonix, and posaconazole, and plus my ibrutinib therapy normally. So it's very important to protect the patients from steroid-induced gastritis as well as protecting the patients from mold or fungal infection. But it's also important to recognize that's going to change your dose adjustment requirements for these P450 interacting medicines.
Perfect, thank you. Now, question to Dr. Shahrukh from Dr. Ahmed Bihraji from Kuwait. How would you treat chronic GVHD eye and oral mouth in a patient who developed steroid-induced AVN and who failed topical and failed Ruxolitinib? What's your take on this, Dr. Shahrukh?
Well, thank you. That's an excellent question. Yeah, that's an excellent question, because the treatment for the ocular GVHD is half systemic and half local therapy. My algorithm is actually artificial tears and then cyclosporin eye drops, and I tell them how to use eye drops. You can have moisture glasses, which are actually special lenses made by the eye companies. But then obviously puncture plugs come in, autologous serum come in, and if not, then scleral lenses come in as well. And if scleral lenses don't work, like Boston lenses, then you could go for cauterization. And this has to happen with systemic therapy, which I'm going to talk to you about in a second. The oral GVHD is a funny thing, because you've got to control the diet, first of all. I mean, you keep on treating the oral GVHD with one after another drug and forgetting that the fluorosis, which can be because of the environment, all because of medications like voriconazole, are contributing to problems. The colas, which have a pH of 1, like Pepsi, are contributing to dental caries and oral GVHD, increasing the risk of caries and periodontitis and the squamous cell carcinomas. You've got to do local therapies with magic mouthwash, very good hygiene, avoid fluorosis, and then systemic therapy. So the question is ruxolitinib and steroid failure, osteonecrosis. So you're talking about JAK-STAT pathways mainly. Well, and we just heard actually, so the acute GVHD is a pure T-cell disease. Chronic GVHD is a B-cell and a T-cell disease. So if you have that JAK-STAT pathway inhibition, which is affecting the B-cell and T-cell, I would really want to add another B-cell agent, whether it's Ibrutinib at that time, or Rituximab. And Rituximab therapy and Ibrutinib, both therapies have shown excellent results in the oral GVHD. Not to mention that ECP has also shown excellent. All these three drugs, treatments, ECP, Rituximab, and the Ibrutinib have shown response rates, overall response rates of greater than 70% in different studies, including 2 meta-analyses for Rituxan and the ECPs that have been published already. But it has to
And
be local, plus systemic.
and when you label ruxolitinib failure, how long you will keep her till you really say it's failed? 6 months at least, or for how long?
Well, that's an excellent question. So the ruxolitinib failure definitions are given in the REACH3 trial, which is a chronic GVHD. But generally, I mean, I have treated many patients on trial and off trial. And typically, once you go to a dose of 10 BID of ruxolitinib, and then for within 3 months, people have effects. But within 6 months, if there's no effect, then I think that ruxolitinib is very unlikely to work at a full dose.
I think we should point out, I did, because of time, didn't show all the non-relapse mortality effects of ruxolitinib on the REACH3 study that Dr. Zeisser presented at his talk, but it was double the risk of non-relapse and complications for infection on the Rux arm compared to BAT. And I suspect that we're going to, and I know from personal experience, I can tell you, I've had patients who were stable for 4 years. I put them on Rux because of what I perceive to be worsening problems. Usually it's my pulmonologist who's worrying me about what is probably an infection, honestly. And suddenly CMV reactivates, adeno reactivates, patients develop PTLD after they've been stable for 4 years. So we are interfering with T cell pathways that, you know, at a time when we're trying to reconstitute immunity. It's yeah. So does the Ibrutinib. So does the ECP. We're just trying to understand the competing need to reconstitute immunity and control chronic GVHD. It will be. There's a lot of work to be done, and I want to reemphasize, you know, what Shahrukh said about putting patients on clinical trial.
Another question from Dr. Ihab Al-Hamidi from National Guard, Jeddah. Which organs affected by chronic graft versus host disease benefit most from use of Ibrutinib?
Yeah, I'll take that one. We don't have the studies that will allow us to point that out yet. Again, the new onset chronic GVHD study with 200 patients will provide much more power. Retrospective analyses always have bias. My own group, based on having a lot of Ibrutinib experience, presented at TCT last year an experience of 18 patients with bronchiolitis obliterans showing some promise. And again, I mentioned Dr. Cutler doing a study of Rockstar, KD025 in bronchiolitis obliterans in his upcoming institutional interest. So I don't think we know what the most effective therapies are. We have seen responses across all organ systems. The initial study, 1129, did not have, it had 2 patients with pulmonary documented. But as I said, we've seen 50% of the patients having decent responses, improvements in FEV1, stabilization of PFTs once starting on Ibrutinib therapy. I look forward to seeing, again, the other agents in those spaces as well.
Perfect. I think this will be the last question to Dr. Shahrukh from our colleague Ahmed Al-Shomer from Al-Qasim. He said, any special advice how to manage GVHD with a graft failure? Patients who are really cytopenic and...
Yeah, that's an excellent question. When they both happen at the same time, hardly any patient survives. Well, let me rephrase the question depending on it's a heme malignancy or is it actually a non-malignant condition. Well, I must say that one of the things Dr. Miklas pointed out was very interesting, and that was actually studies by Corey and Mohammed Moti on the B cell agent Rituximab as a preventative strategy. The reason why that's interesting because when the graft failure happens in heme malignancies, you're looking at a CD3 chimerism, and that's gone actually. The Rituxan doesn't affect the GVL effect of the T cells. It does affect the B cells only. So literally all the graft versus leukemia effect is coming from the T cells. But when that happens together, If the patient has absolutely no cells, you can do a selected boost for some time, but if the GVHD is very active, you're definitely going to kill the patient if you do a full-fledged DLI of any sort. So you've got to be extremely careful, and that's why people are trying to prevent this problem by giving alpha beta versus gamma delta T cell depleted grafts from Seattle study, which is going to phase 3 now. But boy, I mean, if that happens, and which has happened in certain cases early on in transplant, then it's very tough to treat it. I don't know, David, if you have anything to add.
No, it's the double whammy, right? You've lost the graft and you have GVHD. Of course, if it was a malignancy, we would anticipate the patient's also relapsing, in which case now you have the triple whammy. And it's tragic, right? This is really what we want to avoid from the beginning. Many people have said it. I'll just say it again. The best way to treat GVHD is to avoid it. And so what Dr. Hashmi says about alpha beta T cell depletion studies, or any effort really to avoid on clinical trial the development of GVHD is highly warranted. Since I have the podium, I want to just thank Shahrukh again for highlighting that, you know, it turns out Rituximab is still an effective drug that can frequently help you when the patient is very sick with elevated bilirubins and new onset chronic GVHD, and you can give this drug in a safe manner with really very little toxicity. So what I said was it doesn't have long-standing benefits, and the alloreactive B cells ultimately do come back, but it can frequently get you out of a hole, and it can frequently provide you benefit with those new onset, very dramatic chronic GVHD cases, especially when bilirubin is going through the roof. So I don't want you to, I want you to consider that. I think that that's a very safe therapy as well.
Thanks all for participating, and we actually have more than 3,000. Our room actually fit for 3,000, and they keep adding, and would appreciate and thanks all the participants, and special thanks to our distinguished speaker, Dr. Shahrukh Hashmi and Dr. David from California. And I want just to remind everyone that there is all our webinars are fully recording and available free in our society, Saudi Society for Blood Disorders channels. I hope you good evening, a nice day, I mean, in California, and nice good evening in our Arab country. And see you inshallah in our next webinar, which is last Monday of the month. Thank you very much.
Thank you for having us. Mm-hmm.